Hi everyone, this is Dr. Stefan. Welcome to Interstitial Lung Disease Info. In this episode, I'd like to talk to you about hypersensitivity pneumonitis and answer a comment that I got about whether when we have hypersensitivity pneumonitis and we develop pulmonary fibrosis, that is automatically the only reason for breathlessness. So let me read out the comment to you, and then I'll give you a few brief comments along the way. So this is how the comment goes. The doctor is still working on the diagnosis for my dyspnea or shortness of breath. HP or hypersensitivity pneumonitis went to the top of the list when I told her I've lived with birds for 14 years. So again, this could be a trigger for hypersensitivity pneumonitis. We can touch upon that in a second. I'm guessing the long time of exposure, so the 14 years with the birds, means I'm probably not an acute or semi-acute stage, subacute stage of HP or hypersensitivity pneumonitis. There are several stages to hypersensitivity pneumonitis: acute, subacute, and chronic. So we can touch upon this as well. In your experience, is someone already dealing with fibrosis as soon as the dyspnea or shortness of breath with exertion is observed? So I think basically the gist of the question here is whether the breathlessness on exertion that this person is feeling means that there's already fibrosis or lung scarring that has developed in the context of hypersensitivity pneumonitis. And I'd like to just say that obviously this is a very complex diagnosis. So when we are making a diagnosis of fibrotic hypersensitivity pneumonitis, we need to look at a number of factors. It's not such an easy diagnosis to make sometimes, especially because the pattern of scarring on the lungs may not always be very typical. It may be suggestive that that's going on, but just identifying the right trigger is not always easy. And even if this person mentioned that they've lived with birds for 14 years, it doesn't automatically mean that that is the trigger. It doesn't mean that that's the only thing that they've been exposed to. So for example, they've been maybe living with birds because they were working on a farm, and that could be some other trigger in their environment that could actually be causing it. Or it could have been something that is, it could be something that's happening a bit more recently. So identifying the trigger for hypersensitivity pneumonitis is really, really difficult. To be honest, in practice, we, probably more than half of the times we can't really put our finger on what it is. And that's a big shame, because if we were, it would theoretically be able to identify the trigger for the hypersensitivity reaction in the lungs. We could remove that trigger and stabilize the condition without the need for treatment. So that's ideal. But in an ideal world, that would happen. Unfortunately, in most situations, we do end up trying to treat this inflammation in the lungs with corticosteroids or immunosuppressants in the first stage to try to stabilize the condition. And if it's still progressing, if the scarring is still getting worse, we may introduce anti-scarring or antifibrotic medication to prevent and stabilize, to prevent further progression or stabilize the condition. So it's a complicated thing to make. But let me just give you a few thoughts. So basically, with hypersensitivity pneumonitis, like I said, there are three stages, let's just say. So that's the acute, subacute, and chronic. So generally, acute and subacute hypersensitivity pneumonitis happens when we've got an acute reaction to something that we've inhaled. So for example, if you think about maybe a farmer who is working with a lot of hay and they develop farmer's lung. So they may actually suddenly present to the hospital as if they're having pneumonia, because it's basically an acute reaction. They've done a lot of work in the fields, and for example, they've been inhaling a lot of dust and things like that, and those trigger an overt significant reaction in the lungs, and it causes a lot of inflammation in the lungs. They become breathless. It's kind of something that's happening suddenly. Subacute means that maybe the quantity of exposure is a little bit less, so those symptoms may develop over a period of days, weeks, or something like that. So it's a little bit of a slower progress. So with acute HP, acute hypersensitivity pneumonitis, we have an acute reaction because we've inhaled probably a lot of this antigen, this trigger. With subacute, you have a little bit less. And with chronic forms of hypersensitivity pneumonitis, which are more relevant to the pulmonary fibrosis or lung scarring, it's when we inhale low levels of this trigger, whatever that may be, over a very long period of time. And it could be literally years. And in those situations, that chronic inflammation in the lungs eventually may lead to scarring, and the scarring can potentially then get worse in itself. So even if we remove the trigger, but generally removing the trigger stabilizes the condition, stabilizes that trigger because it removes the trigger for that inflammation. So the damage has been done, but generally it tends to stabilize. However, in some instances, it can continue to progress despite that. So that's something that I wanted to tell you. The other thing would be that, of course, with the triggers, this person mentioned something about birds. Birds may not always be the cause. So often we see it, and it's a known thing that we can actually test for. So we can do blood tests and determine whether someone has been sensitized to birds, because they will have these specific antibodies to, for example, pigeon related proteins or budgie related proteins. So it can be a sign that if especially those values on these autoantibodies are those antibodies are really, really high, it may suggest that our body is having a significantly exaggerated reaction to those things, to birds. And there can be cross-reactivity between different species of birds, or sometimes we may have a specific exotic birds. I've seen these sort of instances in clinic where, the antibodies for budgie and pigeon may not be very high, but that person really has a very strong exposure to specific birds, maybe exotic birds. I know this lady who was working in a bird sanctuary, and she only dealt with very exotic birds, things that you wouldn't be common. So again, it could be relevant if someone has a strong environmental exposure to something. If they're working on a farm, again, we can test for farmers' lungs. But other than that, we're quite limited in the blood tests that we can do. So there's also precipitin testing that we can do. So we could potentially just look at specific things, take samples from a person's home or a person's environment, and to try to test this with the person's blood to see if they are reacting to these things. But these are actually quite hard to organize in real life, as you can imagine. You need the staff to go inside the person's home to know what they're looking for. So these things can be done, but I think it's becoming harder and harder, especially in today's world, to do that. So like I was saying, the birds may be the trigger, but it could be other things. So we always need to think about other situations. So what we tend to do in practice, we tend to give an exposure questionnaire. So this is when the person first presents to interstitial lung diseases clinic, they receive a little bit of a questionnaire that sort of jolts their memory about whether they've been working with all kinds of things in the environment. So if they have a lot of mold in the house, if they're working with hay, if they're farmers, if they're growing mushrooms, if they're working with any humid environment, if they have a hot tub at home. All these things can be potential triggers for hypersensitivity pneumonitis, and it may be an exposure that you don't think is relevant. For example, someone may have a greenhouse at home. They use a lot of potting mixes and things like that. That could be a trigger, but we need to tailor it to each individual person. So this is why hypersensitivity pneumonitis is a fascinating disease. It's hard, very hard and complicated to figure out exactly what's going on. In some situations, to try and figure out what's going on, if this is hypersensitivity pneumonitis, we may recommend doing a bronchoscopy or a camera test for the lungs with a bronchoalveolar lavage or a lung wash. So this is when we have a look with the bronchoscope inside the airways. And in one segment of the lung that potentially is the most affected, or in the right middle lobe or somewhere like that, we just put a little bit of fluid, saline solution, and we aspirate that back up. We send it to the lab, and the lab gives us something called a differential cell count. So this is basically to try to see the proportion of inflammatory cells in that sample. And if we have a high proportion of lymphocytes in that sample, it is a very strong indication that we could be dealing with a hypersensitivity reaction or hypersensitivity pneumonitis in that situation. And it can help us to sometimes differentiate between the different types of interstitial lung disease, because sometimes the presentation on the chest CT scan may be similar to other conditions as well. So the other thing would be the CT pattern. If you have access to an expert radiologist, someone who has a lot of experience in looking at hypersensitivity pneumonitis cases, they may be able to identify certain features that may suggest that this is the diagnosis rather than another form of interstitial lung disease, especially if the pulmonary fibrosis or the inflammation in the lungs is mainly around the top part of the lungs, the upper zones of the lungs, because that's where we tend to inhale everything. So most of the air tends to go to the top of the lungs. And if we have more changes there, it makes sense that, and especially if the changes are around the airways, so not necessarily affecting the whole lung, but generally tend to be central to the airway, so bronchocentric, we call that, it may suggest that, again, it's a condition that is triggered by something that we're taking in from outside. So those are things that we look out for. Now, the breathlessness in this question, so the question was whether breathlessness on exertion means automatically that fibrosis is happening. It's very hard to say that. So I'm just trying to give you all the nuances so that you can think through these cases if you're dealing with something like this. it depends a lot on that person's context. How old are they? What other medical problems do they have? So if someone is, for example, a little bit older, maybe in their 60s, 70s, they may have also developed heart conditions, heart failure, things like that. So they may be breathless on exertion because of that reason. It depends on the extent of lung scarring or the extent of lung inflammation. It can be difficult. It can also be a situation in which you may have chronic hypersensitivity pneumonitis. Maybe there's a very low level of scarring in the lungs, but then you suddenly become exposed to a large amount of that particular trigger that's responsible for your condition, and you may develop sort of like an acute on a chronic reaction. So you may suddenly worsen. You have a little bit of worsening because you've inhaled that trigger again. So that can cause another reaction. Also, you need to think about other conditions that may be affecting the lungs. So someone may be suffering with asthma. They may be suffering with COPD, with emphysema, with other medical, other lung disorders that could be responsible for breathlessness on exertion. So it's not always necessarily the scarring that's causing this. And I'm trying to drill this concept down every time I see patients with interstitial lung disease, and especially with even with colleagues in medicine. Sometimes we struggle because if someone has a diagnosis of pulmonary fibrosis, whatever the cause may be, when they're breathless, everyone tends to put it down to that. But some people may have other conditions as well. So it's important to have a holistic approach, collaborate with our colleagues a lot to try to get all the other treatments optimized for all the other conditions that someone may have. Someone may have anemia and then they become breathless on exertion. So again, doing the basic blood tests, the basic things, just to rule out all the potential causes before we think that the fibrosis is the main cause is really important. And then at the same time, someone may not be necessarily breathless on exertion because they are ill. It could be because of deconditioning. So for example, they work a desk job in an office, they are stuck in their car and in their office all day. They don't tend to do as much as they used to. And it's a vicious circle. You tend to do less and less. When you try to do something, you are breathless. That makes you do less and less, and so on. So those are all the things that we need to think about. And I'll just like to end this maybe on with a word on treatment for hypersensitivity pneumonitis. So when we talk about especially chronic or fibrotic hypersensitivity pneumonitis, when we've developed a bit of scarring in the lungs because of this condition, well, it depends on how we choose the treatment. So the first thing and the most important thing would be if we can remove the trigger. If we can identify and remove the trigger for the hypersensitivity pneumonitis, that's the first thing, step one. Like I said, in half the cases or more, we can't identify the trigger. So I tend to give my patients a little bit of homework, if that makes sense, just to sort of have a think whether there's anything around the house that makes them feel a little bit more breathless, wheeze, cough, anything that they can think, maybe organic dust that they're inhaling, if they spend any time in humid places, anything that they're doing around the house that's a little bit unusual, or if something is changed and it's triggering their lungs a little bit. So just trying to identify what's causing it is really, really important. If we can do that, that's the first step, because it allows us to use less treatment. If we cannot identify the trigger, the next step is usually to try to treat the inflammation, to try to control the inflammation, because we're not actually treating the inflammation, but we'll give either anti-inflammatory medications such as corticosteroids or prednisolone, but that can come with its own side effects. So we tend to balance this against the benefits and risks. So we need to always be careful about that. The other step would be to use immunosuppression. So immunosuppression is basically when we give maybe stronger medications than the corticosteroids, but maybe at a lower dose or in a different way that just targets specific sections of the immune system, let's say, to try to control this excessive inflammation that's triggering the hypersensitivity pneumonitis. So that is one thing that we may do in the first instance. Now, more and more, especially in cases where the trigger is long gone or there's just a predominance of the scarring on the lungs. So when we do the CT scans, we just determine that there's more scarring rather than inflammation. In those situations, we may end up going more down the route of anti-scarring or antifibrotic medication to try to prevent further worsening of the scarring. So this is more of the concept towards which we are moving nowadays, because in this condition, like I said, there is a trigger. If we can find it and identify it, that's the best way. If we can't find it and identify it, we tend to treat with to control the inflammation. But if maybe the inflammation is no longer there and actually it's the scarring that's the main process that's driving the condition, then we need to try to control the fibrosis. And there are medications. There's a medication called nintedanib, which is available as an anti-scarring medication, antifibrotic medication that tends to reduce the rate of progression in various types of conditions associated with pulmonary fibrosis that is progressive or worsening in nature. But we may have more therapies on the horizon. There are a lot of trials that are looking into different ways of treating hypersensitivity pneumonitis, because there's a lot of controversy and not a lot of evidence behind the treatments that we currently use for this condition. So I hope you found this helpful. A bit of a long discussion and a bit nuanced, and I'm sorry about that, but I think it's important to know the nuances that we think about as doctors, especially if you're a patient suffering with this sort of conditions. It can be a really, really confusing journey. Thank you very much for watching. All the best and good health to you.